Ms. Ayça Nur Demir from Turkey to deliver her speech, please. Hi. Could you please come with it, please? Thank you.
Hello. Can you hear me?
Yes, please.
Okay. I can share my screen.
Perfect.
Can you see my screen?
Yes, we can see it now.
Okay. I'm starting. Hello, dear professors and dear friends. My name is Ayça Nur Demir. I'm from Turkey. I'm studying in Afyonkarahisar Health Sciences University, Faculty of Medicine, Genetic Department, 5th grade students. Today, I will tell you about coronavirus pathogenesis and treatment methods. During the presentation, I will first talk about the history of the coronavirus, briefly its molecular structure and pathogenesis. Next, I will touch on the COVID-19 disease, a coronavirus replicate and toxicity, its symptoms, and the laboratory techniques used. Then, I will talk about the current COVID-19 data, the measures taken in the world, and the latest vaccination studies. I will give information about a few important vaccines. Firstly, I will tell you about coronavirus history, effects, and pathogenesis. The reports of a coronavirus infection in animals occurred in the late 1920s when an acute respiratory infection of chickens emerged in North America. The virus was then known as infectious bronchitis virus. After, human coronaviruses were discovered in the 1960s using two different methods in the United Kingdom and the United States. Dr. Kendall, Dr. Bino, and Dr. Tyra, working at the Common Cold Unit of the British Medical Research Council, collect a unique common cold virus designed B814 in 1961. Then, Dr. Dorothy Hammer and John Prochnow discovered another virus in kidney tissue culture in 1962 and identified it as 229E. Scottish virologist Dr. June Almeida is at St. Thomas Hospital in London. Collaborating with Dr. Tyrrell, compared the structures of IBV, B814 and 229E in 1967. They, using electron microscopy, the three viruses were shown to be phonologically related. A research group at the National Institute of Health the same year was able to isolate another member of this new group of viruses using organ culture and named one of the samples OC43. Like B814, 229E and IBV, the novel cold virus OC43 had distinctive club-like spikes when observed through microscope. Other human coronaviruses have since been identified, including SARS-CoV in 2003, HCoV 2003, HCoV HQ-U1 in 2004, MERS-CoV in 2013, and SARS-CoV-2, or other name COVID-19, in 2019. This picture is SARS-CoV-2. And now, coronavirus are enveloped viruses with a positive sense single-stranded RNA genome and a nucleocapsid of helical symmetry. The genome size of coronaviruses range from approximately 26 to 32 kilobases, one of the largest among RNA viruses. They have cup-shaped spikes that project from their surface, which in electron micrographs create an image reminiscent of the solar corona, from which their name derives. In humans and birds or other animals, they cause respiratory tract infections that can range from mild to lethal. Mild illnesses in humans include some cases of the common cold, also caused by other viruses, rhinoviruses, while more later varieties can cause SARS, MERS, and COVID-19. And now I want to tell you about COVID-19 disease definition, effects, and pathogenesis. So, coronavirus disease 2019, or other name COVID-19, started as an epidemic in Wuhan in 2019 and has soon become in the world. Groups from China identified and sequenced the virus responsible for COVID-19, named SARS-CoV-2, and determined that it was a novel coronavirus that shared high sequence identity with bats and pangolin-derived SARS-like cause, suggesting a zoonotic origin in this disease. Coronavirus disease is caused by severe acute respiratory syndrome coronavirus 2, or SARS-CoV-2, a member of the human coronavirus family, the lower part of the leg, and causes severe acute respiratory syndrome, or SARS. Now, I want to talk about COVID-19 and coronavirus replication without going into too much detail. Where does the virus replicate? Following replication and subgenomic RNA synthesis, the virus structure proteins are translated and inserted into the endoplasmic reticulum in the cell. These proteins move along the secretory pathway into the array or to Golgi intermediate compartment. In infected cells, the co-RNA synthesing machinery associates with modified array membranes that are transformed into the viral replication organelle. Double membrane vesicles appear to be the central hub for viral RNA synthesis. In this picture, you can see the life cycle of the coronavirus and the replication it has undergone. Viral protein in the cell or endoplasmic go to endoplasmic reticulum to Golgi apparatus. Now, mechanisms of virus-induced toxicity. The virus or the coronavirus may be toxic during the first days. In biopsy or autopsy studies, pulmonary pathology for COVID-19, patients show diffuse alveolar damage with the formation of helium membranes, mononuclear cells, and macrophage infiltrating airspace or other cells, and a diffuse thickening of the alveolar wall. The lungs from patients with COVID-19 also showed severe endothelial injury associated with the presence of intracellular virus and disrupted cell membrane. Viral particles were observed in the epithelial cells by electron microscopy, suggesting that these lesions might be partly caused by a direct toxicity. Now, where we look symptoms of COVID-19. COVID-19 caused by a member of the coronaviruses shares common symptoms with other coronavirus infections and other viruses infections. The major symptoms of this disease include fever, dry cough, fatigue, and mostly appear after approximately 5 or 6 days after contracting the disease. It has been reported that rhonch or rough breathing sounds, as well as coughing fever coming from the lungs. Actually, patients' lungs are the main symptoms of severe COVID-19. Phlegm production, headache, fever, hemoptysis, diarrhea, dyspnea, and lymphocytopenia could also be observed. Then, it has been reported diarrhea to be a major gastrointestinal symptom developed in COVID-19 patients. However, fluctuations in the incidence of gastrointestinal symptoms have also been recorded. Development of various diagnostic methods to detect the virus transmitted through several means is urgently required to minimize this viral transmission. Also, a comprehensive epidemiological investigation, together with modern diagnostic methods, could help in the early detection of asymptomatic carriers. Now, diagnostic tools for COVID-19. What is the diagnostic tools? Methods for the detection of viral nucleic acid, nature of samples tested, and serologic testing. These tests are nucleic acid, serological, antigen, and ancillary tests, all of which play distinct roles in hospital or large-scale population testing. Firstly, methods for the detection of viral nucleic acid. PCR tests for SARS-CoV-2 have been available since January 2020. RT-qPCR-based assays performed on respiratory specimens has emerged as the cornerstone of COVID-19 diagnostic testing. The USA Centers for Disease Control and Prevention has developed a widely used SARS-CoV-2 RT-qPCR. The kit contains PCR primary probe sets for two regions of the viral nucleocapsid gene, N1 and N2, and for the human RNase P gene to ensure the RNA extraction was successful, to avoid potential cross-reaction with other endemic hosts, as well as potential genetic drift, as needs to molecular targets should be included in the assay. Theoretical specificity of most RT-qPCR assays is 100%. Why this methods 100%? Because the primary design is specific to the SARS-CoV-2 genome. Occasional false positive results may occur due to technological errors or rigid contamination. A rigorous assessment of the diagnostic accuracy of the manually introduced SARS-CoV-2 assays is hampered. The sensitivity of viral RNA testing varies with timing of testing relative to exposure. A false positive result erroneously labels a person infected, with consequences including unnecessary quarantine and contact tracing. False negative results are more consequential because infected persons may not be isolated and can infect other persons. Second, nature of samples tested. The current diagnostic strategy to identify patients with COVID-19 is to test samples taken from the respiratory tract to assess for the presence of SARS-CoV-2 specific nucleic acid types. An nasopharyngeal specimen is the preferred choice for testing, but oropharyngeal, mid-turbinate, or anterior nair samples are also acceptable. A pharyngeal virus shedding was shown to be very high during the first week of symptoms, or 10 or 14 days during the first symptoms. The viral load in nasopharyngeal samples peaks between the first few days after symptom onset before declining. For nasopharyngeal specimen, samples should be obtained by using flow swab to enhance the collection and release of cellular material. Samples taken from sputum and tracheal aspirates and bronchoalveolar may have greater sensitivity to upper respiratory tract specimens. Inadequate sample collection may result in a false negative test. Bronchoalveolar lavage, whose specimens had the highest positive rates of SARS-CoV-2 RT-qPCR assay. A single nasopharyngeal swab has become the preferred swab as it is well tolerated and safe. Saliva may also be an alternative specimen source that requires less personal protective equipment and fewer swabs, but requires further validation. And third, serologic testing. Serologic immunoassays have rapidly emerged. Serologic tests that identify antibodies to SARS-CoV-2 from clinical specimens may be less complex than molecular tests. As antibody responses to infection take days to weeks to be reliably detected, their utility for diagnosing acute infection is limited. Serologic assays might be more relevant if serving for asymptomatic infection or scenarios in which patients present to medical care with late complications of disease, when RT-qPCR may be falsely negative. Negative results will not exclude COVID-19 infection. Particularly among those with recent exposure to the virus, the viral spike protein is perceived as the clear candidate for inclusion in an immunoassay that detects whether antibodies are present. And now, the other protein that appears to be important antigen for the development of serological assays is the N protein, or structural component of the nucleocapsid. Indeed, antibodies to the protein are frequently detected in COVID-19 patients, suggesting that M protein may be one of the immunodominant antigens in the early diagnosis of COVID-19. Actually, it is now established that SARS-CoV-2 pre-existing immune reactivity can exist in the general population. Serum samples from patients with COVID-19 showed some cross-reactivity for the SARS-CoV-1 nucleocapsid and antigens. A recent study detected SARS-CoV-2 reactive CD4 plus T cells in 50% unexposed individuals, suggesting cross-reactive T cell recognition between circulating or common cold coronaviruses and SARS-CoV-2. Where we look, as we continue to examine serological tests, we see that ELISA and CLI are common laboratory applications that can measure antibody titers. A variation of these tests can use magnetic protein-coated microparticles known as a microparticle immunoassay. Being able to quantify antibodies built for identify convalescent plasma donors with titers and studying how the immune system responds to the virus. Neutralizing antibodies play important roles in the virus clearance and have been considered as a key immune product for protection or treatment against viral disease. In COVID-19, transfusion of convalescent plasma or serum from recovered patients was also considered as a promising therapy. The last slide for serologic testing. Apart from this test, neutralization test is also used. The neutralization assay is a laboratory-based that uses virus and cell culture methods to determine if patient antibodies can prevent viral infection in vitro. Because immunofluorescence assay is a labor-intensive method, a substantial number of the new commercial COVID-19 antibody tests developed as screening tests are not ELISA-based. They are lateral flow immunoassays, or LFEIE, which provide no quantitative information. These qualitative LFEIE represent typically small, portable rapid diagnostic tests, or RDT, and can be used at point of care. Now, I want to tell you about recent situations and number of cases COVID-19 every day in the world. When we look at the number of cases for COVID-19, the total number of cases exceeds 100 million, while the number of people who recovered approached 80 million, but the number of those who lost their lives exceeds 2 million. And these data continue to be updated every day. When we look at the latest cases, the country that is currently the first in the number of cases is the USA. After that, India and Brazil come in order. Now, this topic is important for me and for other people. Measures taken for COVID-19 in the world. With the spread of COVID-19 around the world, countries resorted to measures to prevent the epidemic, from closing their borders to stopping international flights, from domestic transportation restriction to curfews. European countries, especially when the epidemic increased in Europe, took drastic measures. As a result of the measures, people were prohibited from going out except for basic needs. The necessary police barricades were set up. Governments have tried to alleviate the burden of the pandemic on the economy, support for employees and business. Border closures, travel and transport restrictions, and curfews have grouped countries in daily life and business activities. Under these conditions, public authorities took supportive measures for employees and business to eliminate the negative effects of the epidemic on the economy and the world. Now, this topic is for me and for health workers. With the increase in the number of cases in the countries affected by the epidemic, there was a great burden on health systems, and there were problems in the stocks of sanitary materials, drugs, and medical equipment. Problems were incurred in the procurement of the most basic protective materials, such as masks and gloves, as well as in testing and treatment services. Since the beginning of the epidemic, in the mask stock in my country, Turkey, was not a problem. Training continued all over the world through in the online system for a year. Now, vaccine studies for COVID-19. Normally, vaccines can be applied to quite difficult and long stage in the past. However, the COVID-19 outbreak is a different process, and it is seen that the clinical research path is switched in a few months. One of the most important reasons for this is that there are previous studies on SARS and MERS, which are members of the coronavirus family. Now, I want to a few vaccine about information. This is Moderna. This vaccine developed in the United States uses the genetic material of the virus, unlike previous other vaccines. According to intermediate results of phase 3 studies published in November 2020, the candidate vaccine is more than 94% effective. Then BioNTech Pfizer, as a result of the phase 1 and 2 trials initiated in May, it was observed that the vaccine produced antibodies. According to statement made by Pfizer on November 9, it was announced that the candidate vaccine was more than 19% effective. AstraZeneca British Oxford University, AstraZeneca's 1 and 2, as a result of the fast studies, vaccine developers did not detect any serious side effects. Global trials of the vaccine were stopped on September 6 as the inflammation developed in one volunteer. So, on September 12, it was decided to continue trials partly. According to research results published on November 23 in 2020, the candidate vaccine has developed 70% protection against coronavirus. Then CoronaVac, it is a potential COVID-19 vaccine by the Chinese pharmaceutical company Sinovac. It can be stored in the refrigerator between 2 and 8 degrees. Turkey has received approval to use emergency vaccination in Brazil and Indonesia. The vaccine is a chemically inactivated whole virus vaccine for COVID-19. Sputnik 5, for Russia, on August 11, yet 3rd, announced that it has approved a new coronavirus vaccine, which has now started fast trials. Sputnik 5 phases 1 and 2 were completed on 1 August. It has been said the current clinical trials show that not a single participant was infected with COVID-19 after the vaccine was administered. Phase 3 studies are ongoing. Was 92% effective against COVID-19. And other vaccines, Imperial College London and Engels Osaka University. Imperial College London, researchers developed a self-replicated RNA vaccine to stimulate the immune system. Researchers expect to find out if the vaccine is effective by the end of the year. In animal experiments, a vaccine is safe and produces an effective immune response. Also, Engels and Takarabio, phase 1 and 2 trials of the DNA-based vaccine continue together. Candidate vaccine has been tested on volunteers since August. And now results. In brief, COVID-19 is a serious respiratory disease. Drug treatments were also applied before vaccination studies. However, the common view of scientists has been that a solution to this pandemic can be found with the vaccine. For this reason, vaccination studies have yielded faster results than in the past. and promising results have emerged within a year. A new mutated virus is now spreading, but it has been reported that the effectiveness of vaccines is also valid for AIDS. All over the world, until vaccination is complete, we must maintain the necessary distance, wear a mask, and stay away from closed and crowded environments when necessary. This is my references. Thank you very much. And I would like to thank the Congress team for their assistance. And in addition, the public of Turkey's founder, Mustafa Kemal Atatürk, I offer my eternal gratitude. Thanks to him, we are advancing and developing. Thank you very much for listening to me.
Thank you very much, Ms. Ayça Nur Demir, for such an informative presentation, and it has, opened our eyes about new symptoms that you have explained. So, has anyone got any questions? Thank you. Any questions, please? So, well, I would like to ask you one question. Is there any possibility that this virus is affecting the respiratory centers in the brain also? Is there any effect of this virus on the respiratory centers in the brain, the control centers?
Yes. I read I read about COVID-19 in the brain center, but I'm researching about. I have not more information about this brain center.
That's great. Thank you for letting us know. So now I'm going to invite our next speaker,